Good afternoon. I'm Julia Jacobson, and we welcome you to our presentation for the ACLP annual meeting. The title and what we're going to talk about today is leveraging ethical principles when managing eating and feeding disorders and complex capacity concerns in transitional aged youth, a practical approach. This is my disclosure, and I'm just going to start by introducing myself. I'm Julie Jacobson. I'm a child and adolescent psychiatrist, as well as board certification in general psychiatry and consultation-liaison psychiatry. And I'm the director of the Pediatric Consultation-Liaison Service at Children's Hospital in Los Angeles. I'm also a professor of psychiatry and pediatrics for the Keck School of Medicine for USC. And I have nothing to disclose. Just the aims of our talk today, through a review of 3 complex cases provided by 3 different presenters, we're going to discuss navigation strategies and also try to highlight some pitfalls to avoid when considering capacity in transitional aged youth with complex needs. We're going to review some practical tools to support multidisciplinary team alignment. We're going to try to demonstrate how ethical principles can be applied in complex clinical situations and comment on countertransference and moral distress that is often experienced by care teams. So just thinking about transitional age youth, which is adolescents as they're entering adulthood. The World Health Organization put out a position statement on this in 2017 and really highlighted that supporting emerging autonomy positively impacts healthcare utilization of adolescents. And just in that context, thinking about youth at that age, capacity assessments, especially for patients who have both psychiatric and medical needs, can be inconsistent, and that challenge can be amplified during times of change. So when you receive the consult, the considerations for the youth that are requiring the medical and the psychiatric concurrent care, the consultant is thinking about balancing autonomy with beneficence, just being very aware that capacity assessment is fluid and it should be consistently assessed, and ideally at multiple points during the course of the hospital stay and the care. And also just really being aware that structural inequities and care disparities do matter as a part of this assessment. The practical tasks for the consultant, really the liaison part, is thinking about multidisciplinary team alignment, and the complex shared decision-making that has to happen, both from multiple members of the care team, but also from the minor youth and their support systems. And again, to be aware of pitfalls and try to avoid them. So we're going to shift over now, and I'm just going to go over the first case. This is a case that presented to our hospital a couple of different times for quite lengthy hospitalizations. This patient was a 17-year-old Black female. She's quadriplegic following a motor vehicle accident that occurred about 4 years ago, where she sustained a C4 spinal cord injury. And resulting from that, developed spastic quadriplegia, had a neurogenic bladder, and required catheterizations frequent times during the day, got UTIs not infrequently, and developed nephrolithiasis at times, also had neurogenic bowel, had intermittent hypotension due to poor vasomotor tone, frequent episodes of nausea, cholelithiasis, a history of osteomyelitis, and then chronic abdominal pain. The social part of the history, this minor is a ward of the court and had been in multiple prior medical foster care placements and was currently placed at a skilled nursing facility. Mind you, the skilled nursing facility was in the county where we are located, but the county of origin was a different county, more than 60 miles away. And the child, she is in contact with her biologic family. The reason for removal was not neglect or specific abuse, but they could not care for her medical needs, which are complex, as I've highlighted, but they remain a source of support. In terms of past psychiatric history, she had, around the time of the accident or shortly thereafter, been trialed on duloxetine, had been diagnosed with some depressive symptoms. Psychotherapy had been recommended and trialed. And it had been tried when she went into the foster care system at different times. It had been quote unquote mandated by the court, but she really was refusing the ongoing psychotherapy, but had not been on a psychotropic for a couple of years when we came into contact with her, and really refused ongoing behavioral health support just prior to coming to the hospital. And also, I think importantly, throughout the entire initial hospitalization, really was not interested in engaging with the psychiatric or psychology support teams. So she would present with concerns that at the skilled nursing facility, she's eating less, losing weight, malnutrition is worsening. There are these frequent UTIs, skin breakdown was identified. So the reason for the hospitalization, or the presenting reason, would be a UTI, and then it would turn into this kind of extended hospital stay. Nutritionally, she's able to eat. Sometimes she would DoorDash food. She would go down to the farmer's market or get the nursing staff to take her down to the farmer's market that happens here once a week and buy things and eat them. But at other times would refuse to try to eat, would refuse enteral feeds. And staff felt that this was inconsistent in terms of the reason why. It wasn't necessarily linked to bloating or emesis or her being ill appearing in other ways, but an extensive GI workup was undertaken and completed and was reassuring, including with the imaging, including endoscopy. And so during the first hospitalization, at that point, the team decided that we would initiate an eating disorder care pathway focused on avoidant restrictive food intake disorder, thinking maybe there's a restrictive eating component here. And she really just refused to comply to that. Our care pathway involves structured nutrition at set times. The patient gets, 30 minutes to try to eat what they can, and then it's whatever nutrition they were not able to take in is provided in liquid form. And if they're not able to drink that after a day or two, an NG2 is placed, and the supplemental nutrition is provided in that way. She would report significant pain with enteral feed. She would refuse that, scream when the staff was providing that at times. And the medical team decided to try running feeds at night. She would wake up and tell them to halt. She could not disconnect herself, of course, because of the paraplegia, quadriplegia, and limited ability to move her arms. But nursing staff did not feel comfortable feeding when a patient is expressing this level of distress. So ethics was consulted with the question, could we do stealth feeds, was how it was framed on the medical team side. And the ethics consult did not support that after some sort of extended discussions. And so I'm just highlighting that were multiple barriers to developing coordinated treatment and disposition planning, and getting the patient to buy in was a primary challenge. She was actually sent back to the skilled nursing facility and then returned to the hospital about 4 months later, was further malnourished. The skin breakdown had worsened because of the level of malnutrition, or at least that was one big component of it. And during the second hospitalization, we shifted, and the team tried to focus a little bit differently on how we interacted. We tried to understand, since the biologic family is the main source of support that's described by this patient, and mom would be on the phone at times when we were trying to provide care and talking to the nurses. The social workers went back to Child Protective Services and really requested that we involve mom more. In the first hospital stay, we had been told, do not involve mom in the care planning, but we really went back to say, we want to involve mom. We'd like to try to involve mom more, and we're able to get the court to shift that. And also to involve the patient more. This is 6 months later, the minor's now 17, I'm coming into 17 and a half. And so we were really speaking more directly to the patient about these decisions. Also listening to her, and with the ethics input that the main point is to provide nutrition in a way that the patient would accept. They were able to initiate TPN, which did provide at least more nutrition, and actually got consent to place a G tube, and then continue to work with her on feeding as possible. A multimodal pain approach was also used. Patient was more willing with some of this support now from mom and the team to accept psychiatric involvement and psychology involvement during the second hospital stay. And the pain team actually placed an epidural catheter for about a week, and there was no change in her symptoms. And they were able to help her and her mother understand that that was probably a good indicator that some of the symptoms were more functional and neuropathic in nature, and may have an anxiety component. So she could start to express that distress that she had been describing as pain as more anxiety. They did trial ketamine for a time, which did not go well, but when the patient and the mother understood that that's an anesthetic for pain and it was not helpful, that maybe what we're treating is not pain, but it's more, again, the functional neuropathic component. Psychiatry was able to trial mirtazapine, which she didn't really tolerate or want to continue, but then retrial duloxetine, which was helpful. And a psychologist at our institution, she accepted more regular meetings with her and some family therapy sessions, all of which eventually led towards successful placement. So just thinking about, areas of ethical concern that come up when you're thinking about a complex case like this, with so many different factors. In thinking about consent, and specifically consent for transitional aged youth, and also consent for youth in congregate care placement. When children and youth enter foster care, the child welfare system is responsible for making sure that their medical needs are met. But it can be so bureaucratic that it's important to try to figure out a way that they're met in a timely way and that the appropriate people are involved. And so a systems of care issue is highlighted when so many different agencies, when it's healthcare at the hospital and child welfare and the court and the family, who's actually responsible for making decisions and then following through with decisions. And then finally, just commenting on motivation, because with the case that I just described, there were considerations on the part of the care team that some of this was being done for secondary gain, meaning the patient did not want to live at the SNF, did not enjoy living at the SNF, did not want to be a county away from her loved ones, but also told us many times she preferred the hospital, the pediatric hospital, to the SNF. And so there were comments at times from caregivers that maybe this is some of the symptoms that were being presented and described by the patient were to reach those secondary gain goals, and really trying to take a step back and say, does motivation matter? Thinking about consent and reasons to involve the minor, and especially a mature minor on the older edge of the minor spectrum. When we're thinking about autonomy, supporting emerging autonomy is important, and medical decision-making can help to develop autonomy and also respect autonomy that is already present in the youth. In terms of control, these youth have very little control over their lives, especially youth in congregate care, which is a group home setting or a skilled nursing facility setting where there's multiple other clients and multiple staff. It's not just the minor and the caregivers, just a couple of caregivers. It's much more of a bureaucratic situation, right? And so they have very little control over their lives. But at the same time, these youths do have necessary knowledge. They know their own symptoms and the issues they're experiencing more often than anyone else. So I just wanted to bring up the point that involving biologic parents and the child welfare system together, while important, can take time, and the decisions can be challenging. So what if we just divide decisions up and really separate decisions around routine care versus serious decisions versus life and death decisions, the same way we do when thinking about capacity, when we're thinking about minors being able to consent for psychotherapy or some of the more routine care that there are already statutes describing. What about using an age-based spectrum of decision making, where 14 years and older who meet capacity requirements can make those decisions for routine care, even routine medical care? 16 years and older can make more serious decisions, including decisions about nutrition, including decisions about medication. And then 18 years and older with capacity continue to make those most serious decisions, including like DNR or refusal of life-sustaining therapies. Because making decision returns control to the youth. It's decisions about their own body, and it also gives them some impact, right? That they can make these choices over their own health, informs their control over their entire life. And the fact that some of these decisions are important can also help the youth to gain some sense of control, because other decisions, often when they're living in group homes or congregate care settings, cannot be individual. Those are more made for the entire facility. And then there's going to be some other discussions of capacity, ways to assess capacity. There are several different ways to do this, but I just wanted to bring up one from Dr. Chow in an article where he described thinking about this as a curve, with using the curve mnemonic, where you choose and communicate. Then the patient needs to be able to understand what's being recommended, that there's an assessment of the reasoning, both their own pre-morbid reasoning abilities but also the reasons that they're making the choice that they are, and what are the values that they attach. So thinking about that curve mnemonic, these are the specific questions you're considering when you're talking to the patient. Can they make a choice? Can they understand what the choices are that are available? And are they able to clearly communicate both the choice that they make, but why, and that it aligns with the pre-existing values that they have? So with my case, going back again, when they agreed to acknowledge that there's an impact of psychiatric illness and accept care for that and gain some control back, especially around both the care for their own body, but also where they would want to be placed, and working on any kind of ways that could be adjusted. And that really required involving all the systems of care and opening the communication between them. That was when we were able to find some success. I just added a bit at the end here of this case to think about forced feeding, because there have been discussions in the ethical realm around this. Really, that it's allowed if there's acute risk of death for medical complications. In medical settings, it's that acute risk consideration piece that's a challenge. If the minor has questionable or lacking capacity, you go to the designated decision maker. But what if they do have capacity? What if the patient is competent? Then for adult patients, courts have considered that they have the right to decline medical treatment, including artificial feeding, and that if their competency changes, their designated decision maker should try to go along with their pre-existing values. But of course, that's with caveats. One of the big ones being that any existing psychiatric illness has been treated that might factor into the decisions that they're making. More recently, courts don't allow force feeding for prisoners on hunger strikes. And patients with life-limiting conditions can refuse life-extending care, including artificial nutrition. And there have been some recent court decisions, including around a patient with anorexia in 2017, where New Jersey said that that patient could forego artificial nutrition and hydration. And I put that into the references. It's a very interesting case. The caveat is that that patient was not a minor. They were 30 years old, and there had been years of psychiatric treatment with nutrition being provided, and the court shifted their understanding of that patient as having a life-limiting condition and shifted to palliative care in that case. And then finally, just to leave you with some of the team alignment strategies that we tried to use, thinking about how to get everyone on the same page. Now, I'd like to introduce Dr. Roberto Ortiz-Aguayo. He's a graduate of the University of Pittsburgh Medical Center Triple Board Program in General Pediatrics, General Psychiatry, and Child and Adolescent Psychiatry. And he also received a master's in medical management from the Carnegie Mellon University. Dr. Ortiz-Aguayo, his work focuses on the care of children with complex physical comorbidities, as well as development and operations of systems of care and graduate medical education. He's currently the Chief of Psychiatry at Nemours Children's Hospital at Delaware Valley. He's a Fellow of the American Academy of Pediatrics, Fellow of the Academy of Consultation-Liaison Psychiatry, and a Distinguished Fellow of the American Academy of Child and Adolescent Psychiatry.
Thank you, Dr. Jacobson, and thank you all for watching our webcast. I'll be talking about practical ethics in decision-making when dealing with transition youth age with developmental disabilities. With regards to this presentation, I do not have any conflicts of interest to declare. We're reviewing developmental disabilities, some legal milestones and ethical frameworks. We'll discuss decision-making support spectrum, and we'll touch on some practical tools for the different professional roles. Just anchoring with a case, this is a 19-year-old with trisomy 21, along with multiple comorbidities, including a pediatric ward, neurogenic bladder, and thyroiditis. Presented with a history of developmental regression, refusal to eat primarily manifested by a complaint of odynophagia, loss of communication, admitted for malnutrition, ultimately diagnosed with catatonia and suspected down regression syndrome. Further review of her history demonstrated that there were signs of cognitive and motor regression for at least 1 year prior to presentation in multiple outpatient medical appointments. Despite this, the patient continued to retain full decision-making authority. Treatment challenges during the care was that there were limited responses to pharmacological strategies, which led to the recommendation for ECT. Legal and guardianship barriers delayed treatment, and there was acute morbidity in the context of prolonged hospital stay, including multiple hospital-acquired infections and deconditioning. There are also systems gaps in that the patient remained hospitalized due to limitations in access to adult facilities for ECT, further exacerbated by legal requirements. The patient was hospitalized in a state in which next of kin could authorize electroconvulsive therapy. However, insurance would only pay for ECT in her home state, and that home state did require not only legal guardianship, but a specific writ that allowed that guardian to authorize treatment with electroconvulsive therapy. That certainly further delayed our ability to access care. Just as a systems note, the hospitalization was over $2 million in direct costs, not accounting for non-billable services, which are plentiful during these prolonged admissions. and our expected reimbursement rate is only approximately 40%. Thinking about some core topics, we're thinking about patient autonomy versus beneficence, balancing the respect of the patient's autonomy with the need to provide beneficial medical care, can create an ethical tension in decision making, as we knew that this patient wanted to maintain decision making based on prior conversations with outpatient providers and her family. The family also valued her level of independence. And it was a process for them to understand that in order to move forward, those goals needed to be revised. There were legal inconsistencies across states, as I mentioned, that needed to be navigated and caused further delays of care. We'll also note that these processes can bring a financial burden that not all families can engage in the timeframes that we would like for the processes to be completed. In retrospect, I think that we also noted that there were lost opportunities for proactive legal planning in the shape of like missed opportunities for anticipatory guidance, planning for contingencies for whether, in case that the patient were to lose her ability to consent as she did. And there was a lot of moral injury that came from that when managing the medical teams. Taking a step back, talking about the impact of developmental disabilities. Developmental disabilities affect cognitive, behavioral, and adaptive functioning, influencing independent decision-making abilities. About 8.4 million people in the United States live with intellectual and developmental disabilities, with 73% of them being children and about 27% being adults. And obviously, this is a moving figure. At 18, legal capacity is assumed, but many patients' conditions do not actually reflect the ability for decision making. It is thus very important to initiate early transition planning. The American Academy of Pediatrics suggests that planning starts at ages 12 to 14 to ensure proper assessments and support for decision-making capabilities, contingency planning, as well as the legal maneuvering that needs to occur to support those decisions. Optimally, families, healthcare, educators, and legal experts will collaborate to uphold the autonomy and the well-being of the patient. We graduated support decision-making arrangements that protect the rights of the patient while promoting the least restrictive alternatives to manage the presented circumstances. Just a note on a couple of legal statutes and precedent that support the overall goal that patients with developmental disabilities should be protected and encouraged to have self-determination to the best degree of their abilities, should not be discriminated against for access to care or services, and that the overall guiding principle should be to promote the maximum degree of autonomy and as such promoting their dignity as the individual. Looking at some models of alternative decision-making, we would start with independent decision-making, in which the individual makes decisions with minimal or no support, and this emphasizes the most degree of autonomy. Supported decision-making, it's an arrangement in which the individual retains authority, but can receive help from trusted supporters to understand and communicate decisions. This requires team collaboration, but does not necessarily require legal maneuvers. Medical proxies and powers of attorneys are legal arrangements that allow designated persons to make decisions on behalf of the individuals in specific contexts, and this can be both for financial and healthcare decisions. And then guardianship, which is considered the most restrictive level of supported decision-making, It is a process through which the court has appointed a guardian to assume decision-making authority, prioritizing protection over autonomy. When we look at individuals with developmental disabilities, most end up with guardianship, and we think that factors that impact that distribution include risk aversion as well as legal conservatism, often at the unfortunate impact over the patient's possibility of having had a more autonomous decision. It's a comparison looking at the general population, patients with other neurological disabilities and specifically Down syndrome, as we know that patients with Down syndrome have even lower rates of successful transition compared to other youth and compared to other youth with developmental disabilities. This is thought to be caused by lack of trained providers, poor pediatric adult services coordination, lack of insurance coverage for transition systems or transition visits, as well as limited legal readiness, which ultimately impact transitions most often and unfortunately during crisis events. The core outcomes for successful transition include having an adult provider, having proper insurance coverage, and having the ability to take responsibility for self-care to the best of their abilities. In our capacity as providers, we should always be focused and encourage early planning, interdisciplinary collaboration, and advocacy for policy reforms that support inclusive transition programs across systems of care. Just to touch on the impact of psychiatric comorbidities in transition planning with youth with developmental disabilities, there is a higher prevalence, and psychiatric conditions can impact the capacity evaluation of the patient. And as we know, capacity in itself, it's non-static state that requires further evaluation. There is need for targeted interventions to decrease the burden of the psychiatric symptoms that may be impacting the individual's capacity to perform effectively. There are real challenges with regards to impaired executive functioning, communication difficulties. This was also highlighted in our case by the way that the patient stopped signing, which was her primary way of communicating, but we were able to get some information on how she was describing her feelings and experience through the use of communication devices. And so it's always something to think about that improving ability to communicate should be used when trying to assess the person's capacity. Patients may have reduced ability for self-advocacy and require a structured support process by multiple professionals in order to ensure successful transition and continued care. We've talked already about the barriers to access, and then in addition to that, there are service gaps in terms of fragmentations between systems of care for patients that are youth versus now adults with developmental disabilities, family and caregiver struggles, including access to family members that can care and advocate for the patients effectively, and the ongoing need to close the gaps in access to multidisciplinary care with experts in holistic patient care. Some practical steps include early discussion, as we mentioned, initiate transition planning at as young as 12 to 14, communicate and document the preferences of the patients, include the use of communication tools to enhance readiness and inclusion. Um, Start having conversations about what are going to be the legal decision roles for the patient and for those who will be supporting them, and how can there be a spectrum of transition and decision making based on the situation at hand. Coordinate with providers across pediatric and adult healthcare systems to try to ensure the best continuity of care. And whenever possible, there is evidence that supports that integrated care clinics do have better outcomes in successful transition for individuals with complex needs. Just a brief summary of some of the ethical issues that we face with the case and a summary of the conflict. And just a graphic presentation of what were some of the conflicts, so that's such as autonomy versus protection or beneficence, capacity versus competence, youth versus family control, and what were some of the actions, which included the use of supported decision making, assessing capacity regularly, engaging the youth in care when possible. We also address disparities, financial constraints, and incomplete transitions. And some of these are more systemic interventions, including the promotion of creating medical homes, advocate for reimbursement models that support transition planning, and also cross-train adult providers for managing patients with chronic illnesses that begin during the pediatric years. Finally, some references. And now I would like to introduce our next speaker. Dr. Rajagopalan is an assistant professor in the Division of Child and Family Mental Health and Community Psychiatry in the Department of Psychiatry at Duke University School of Medicine. Clinically, she works as a pediatric Consultation-Liaison and emergency psychiatrist at Duke Children's Hospital and supervises residents, fellows, and medical students as the site director for pediatric psychiatry. She provides consultation to primary care via the North Carolina Pediatric Psychiatry Access Line, and she's also an interventional psychiatrist in the Duke Electroconvulsive Therapy Clinic. Academically, she enjoys contributing to education around feeding and eating disorders and to institutional efforts to operationalize care guidelines and clinical pathways for first episodes of psychosis and catatonia.
Thank you so much for the kind introduction. I'm Aishwarya, and I'm going to talk a little bit about some of the complex decision-making dynamics we can face with emerging adults, particularly receiving care in the general pediatric setting. With regards to disclosures, I do not have any. Here is my formal statement. So many times we get consults that seem like we're navigating a maze. We're trying to bring together a multidisciplinary team, and we're guiding systems, and we're trying to find alignment and engage in shared decision making. As CL psychiatrists, we not only address clinical issues, but we also are party to addressing team and structural dynamics. This saliently is tested in the care of our transitional age youth and emerging adults, particularly when we struggle to adapt our care paradigms for chronological ages that may not account for developmental stage. In particular, we're balancing autonomy and beneficence. So in this case presentation, I really hope to highlight balancing autonomy versus beneficence, particularly for emerging adults with severe eating disorders, using a composite case of several young adults we have seen with severe eating disorder presentations, and how a couple of diverging paths can differ due to varied levels of alignment with the surrogate decision maker and the treatment teams. So we'll start with an initial case presentation and highlight the autonomy versus beneficence tension, and then we'll talk about differences between when the family is in alignment and the family is in disagreement, using family as a general term for biological, non-biological, and structural components for caring for an emerging adult. So we will talk about Ash, a 20-year-old young adult with past medical history notable for anorexia nervosa, restrictive subtype, generalized anxiety disorder, and asthma, who is admitted to the general pediatrics floor given concern for hypoglycemia after declining oral and nasogastric tube administration of nutrition at an eating disorder facility. And psychiatry is consulted for a couple of reasons: administration of the eating disorder protocol and assessment of competency to make medical decisions. So I have highlighted for you some of the things that stand out to me besides the clinical instability of the patient, right? So a 20-year-old admitted on a general pediatrics floor, protocolized intervention for eating disorders, and then this question about decision making. So thinking about transitional age youth, we've talked about this a couple of different times in our presentation thus far. Minors are generally assumed to lack decision-making capacity globally. They are usually in the care of someone else, whether that is a guardian or a system. And at the age of adulthood, they transition to having assumed decision-making capacity unless they are condition or system limited. So, guardianship already in place or other considerations may be in place. But one thing to consider is that there can be some unique challenges being a chronological adult, as in age is greater than 18, but currently receiving care on a general pediatrics floor where the average patient is assumed to lack decision-making capacity. So thinking about the adult on the pediatrics floor, systematically, our pediatrics floors are geared towards caring for children and adolescents who are not their own autonomous decision makers. So this can lead to a variety of challenges, including mismatched expectations between patients and teams, discomfort with some of the nuances surrounding capacity, and power struggles even around some of the most basic policies. So there may be unit policies around quiet hours or protocols around electronic use that can present real difficulties for adults who are used to a certain level of autonomy that differs with what is generally expected in that pediatric setting. Eating disorder protocol, Dr. Jacobson highlighted how that works at her institution, and ours is quite similar. There are standard parameters for nutritional restoration. And so this delineates specific meal plans with calorie targets and requirements around purge precautions, electronic use. And we use this to provide scaffolding for all members of the care team and to reduce variability in the plan, particularly where there have been historical challenges with adherence based on shift and who's available. But this can also be an additional challenge for our young adult patients because flexibility is a value that adults come to appreciate. So that's just something for us to keep in mind. Another benefit of the protocol approach is that it also sets out clear expectations for early engagement of a variety of consulting teams. So kind of going back to our case, there was a call for an assessment of global decision-making competency around medical decision-making, which is a concern that is often requested when we have chronological adults on a pediatric floor. And so we often will have the conversation that the question they may be asking is decision-making capacity for an individual decision in a moment in time. And so a commonly utilized framework is the Applebaum and Grisseau criteria highlighted here, including communication of a choice, understanding relevant information, appreciating a situation and its consequences, and reasoning or manipulating that information to treatment options. And so we as CL psychiatrists know that this decision-making capacity is specific to a decision and it's dynamic, and it's a capacity, it's not a competency. We're not sort of exercising legal. So I will talk to you a little bit about the fact that decision-making capacity in the hospital setting requires this assessment of the value of autonomy versus beneficence. And this can come to a head in the care of feeding and eating disorders in particular, because our society trends towards autonomy. But we know that feeding and eating disorders can impact decision-making, particularly in severe presentations, as malnutrition sets in, as there can be malnutrition encephalopathy, and as a core function of restrictive eating disorders, oftentimes having the value of the eating disorder replacing the values of the person. So getting more specific information about ASH. On the morning following inpatient admission, psychiatry, adolescent medicine, general pediatrics, and nutrition are all co-rounding and discussing with ASH the plan of the eating disorder protocol. ASH declines the plan. They say that they feel fine, but on finger stick, their glucose is quite low and they appear unsteady in their room. Their serum glucose from their morning labs also corroborate hypoglycemia. So in the moment, there is a request for psychiatry to weigh in on capacity to decline nutritional intervention. So doing a quick ad hoc capacity evaluation, ASH is communicating a choice to decline nutrition, but there's a question that we're asking of, is this consistent with their pre-morbid values? So before this episode of care and even before the development of the eating disorder, does this sound like something they would align with? And understanding the relevant information, this part is difficult to discern because they continue to report that they're fine in the presence of evidence to the opposite, right? So they're unsteady on their feet. Their labs are suggesting that they're likely not faring well. And appreciating the situation and its consequences is one domain that can be heavily impacted by the eating disorder, the real representation being statements to the effect of, I'm not that sick anyway, or I could be more sick. I'm not the sickest I've been, so I'm not that sick anyway, does not reflect the reality of being medically hospitalized and hypoglycemic. But reasoning and manipulating information, ASH is able to verbalize to you, if I don't accept food or supplement, you'll put that tube in my nose. So expressing awareness of the protocol's progression from oral nutrition via food or supplement, and then transition to NG tube. In the moment, they are assessed to not have capacity to decline nutrition. And so we engage their surrogate decision maker. They don't have an established guardian. So this brings up a critical issue of surrogate decision makers. So many young people do not have established surrogate decision makers. So they have not appointed someone as power of attorney. They have not, set up legal documentation around this. And so at my institution, next of kin is assumed if there is no identified surrogate decision maker. And that can be with variable success depending on relationships. So important things to consider as well, particularly youth may travel for nuanced eating disorder treatment. So location of their surrogate decision maker may not be proximal to your institution. The durability of their impairment may cause you to have other conversations or considerations about whether you may need to pursue a longer term solution, which may include guardianship, and then also the values of the surrogate decision maker. So a question that can come up is the surrogate decision maker likely to act in collusion with the feeding and eating disorder? Are they likely to act in the patient's best interest from the perspective of the clinical treating team? So in this instance, the general pediatrics team called the patient's father to identify him as next of kin and let him know that the patient was lacking decision-making capacity in the moment, and therefore we were turning to him for his assistance with support. So in his role, he reports that the pre-morbid values were around maintaining safety and overall survival. So he, in this instance, therefore consents to provision of nutrition in this emergent situation over objection via NG tube. And we discussed that with the patient, who then reluctantly accepted oral nutrition without the placement of the tube. However, there have been instances on our service where when we call the father or the identified next of kin, the family says they don't align with any further provision of nutrition beyond this immediate stabilization. And so we've had multidisciplinary meetings held even the same day with the family, and they raise the fear of losing their young adult child. And so they say they would like their child to arrive at understanding of the need for treatment in their own time. So they will allow us to do the emergent nutritional stabilization, but beyond that day by day, they want assessment of when Ash is able to make their own decisions. And they will consider our guidance around considering guardianship given the chronicity of illness and impairment, but would like to do that in the outpatient setting rather than in the hospital. So what did we think about as a treatment team? And so kind of some of the things that we thought about were the utilization of tools like a medical hold, which we can utilize when patients are critically ill due to medical complications. And so those would be things like electrolyte abnormalities, cardiac arrhythmias, those types of things, versus an involuntary commitment, which we could place if we felt that the psychiatric symptoms were the predominant driving factors. So what we had discussed with the medical team was, while the vital signs and lab assessments met sort of a criteria of instability, consider placing a medical hold if the patient requested to self-direct their discharge while attempting to discuss with their next of kin how best to proceed. We also talked about considering manners of pursuing treatment over objection, the role of a guardian in this situation due to chronic decisional impairment due to the psychiatric condition of anorexia nervosa. One thing that's worth highlighting here, though, is that many eating disorder treatment centers require patients to assent to treatment, even if they do have an established guardian. And chief among the things we considered was continuing to build rapport with the family. So trying to align with them around their fears of loss and really working towards stabilizing the most acute element of the crisis and then building relationships moving forward. So kind of taking the next step, right? When the parents align around that acute nutritional stabilization, but then declined pursuing guardianship, we saw the patient sort of, as they were nutritionally restoring, having more cognitive restoration, aligning with the nutritional restoration piece, but declining further eating disorder treatment. So then in that instance, parents stated preference to discharge home and reevaluate engagement in treatment. So they discharged home. And so in these instances, we have seen our patients like Ash be hospitalized in several different institutions with continued progression of illness. So what can we do to support our large teams and systems of care, particularly partnering with support systems of our emerging adult patients? So in our institution, we start with early multidisciplinary huddles within 24 hours of admission. We hope to establish our roles and delineate what each party's responsibilities will be so that we can have a clear, cohesive message and reduce the risk of splitting, which is indeed a vulnerability in the care of folks with severe restrictive eating disorder presentations. We also leverage the opportunity to co-round daily so that we can have forward progress in the treatment agenda and also have everyone on the same page in terms of these really nuanced and dynamic capacity assessments. In addition, we try to center pre-morbid values. This is really challenging in restrictive feeding and eating disorders for multiple reasons. First of which, illness onset can be at a very young age. And so there may not be the most clear and consistent source material for one's pre-morbid values. And so collateral can be helpful for this. We also try to contextualize the impact of malnutrition, encephalopathy, and chronic malnutrition impacts on cognition. And this can help us to understand what targets are for when someone's decision-making capacity may be better restored. And lastly, and perhaps most importantly, is recognizing what is negotiable and what's non-negotiable in the care of our folks with severe restrictive eating disorders, particularly hospitalized for nutritional restoration. So there are, of course, moments where high fidelity to a protocol is vital. We saw that in Ash's case in a moment of acute hypoglycemia with real symptomatic impact, but there are also opportunities for utilizing principles of harm reduction and joining with our patients and their families to try and leverage building better rapport to enhance kind of progress in the treatment agenda. So with that, I will transition to our take-home points. Nuanced capacity assessments are key. Particularly in restrictive feeding and eating disorders, we can overestimate our patients' understanding of illness, in particularly bound by societal body image concerns in a fat-phobic society. And then we can also misunderstand chronological versus developmental ages. So we may see an adult numerical age and not contextualize that being ill for a prolonged period of time may impact the development of one's cognition and development of one's own value systems and belief. And then in addition, fostering communication is essential, right, to collaborating with complex teams. So this is where multidisciplinary engagement and rounding starting at the time of admission can make a really meaningful impact. You've heard each of us comment on the dynamic nature of capacity and then the vital nature of frequent reassessment to ensure that we are always providing the most timely assessment. But then also noting that there are systemic barriers. These things vary institution by institution, state by state, and noting that guardianship itself is not a one-size-fits-all solution. Many treatment programs require assent or consent of a patient, even with a guardian. And so that can be a real challenge if we're not thoughtful about what are the needs of the patient in the moment of time. So these are my references. And with that, I will thank you and stop sharing my screen so that I can introduce you Dr. Ihle, MD, PhD, who is a neuroscientist and double board certified psychiatrist, certified in general psychiatry and child and adolescent psychiatry, who treats children, adolescents, and adults. She is a health sciences clinical professor at the University of California, San Francisco in the Department of Psychiatry and Behavioral Sciences. She has served as the interim director of the Inpatient Pediatric Psychiatry Consultation-Liaison Service and associate director of the Child and Adolescent Psychiatry Outpatient Clinics at UCSF. Most recently, she has been appointed program director of acute and hospital-based services at the UCSF Benioff Children's Hospital, Oakland. She currently provides psychiatric consultation to community pediatric clinics and is an attending psychiatrist on the Pediatric Psychiatry Consultation Liaison Service at UCSF BCH Oakland, and will be providing our summarizing discussant remarks. Thank you so much, Dr. Ihle.
Thank you, Dr. Rajagopalan. It's a privilege to be the discussant for this general session, which has described the practical approaches to leveraging ethical principles when managing eating and feeding disorders and complex capacity concerns in transitional age youth. My discussion will review the 3 presentations and will consider additional principles that can be salient for CL psychiatrists working with medically complex patients. I have no conflicts of interest to disclose. I'd like to start this discussion by thanking my colleagues, Dr. Jacobson, Dr. Ortiz-Aguayo, and Dr. Rajagopalan, for a wonderful set of presentations describing the ethical principles and complex capacity concerns of transitional age youth with eating and feeding disorders. All 3 presented on promising developments regarding systems of care, more equitable resource allocation, resolutions for care disparities, and strategies for collaborating with treatment teams. They also highlighted some of the pitfalls associated with imposed treatment and other ethical dilemmas encountered by care teams working with transitional age youth who may have eating disorders, but who also may have disordered eating and feeding. My discussion will elaborate further on these pitfalls, with a particular focus on the challenges related to the moral distress and other reactions of care teams. I will conclude with a summary of recommendations that can offer the promise of principled interventions for this patient population. I'll start with an observation of general themes. The issues of nutrition, more specifically of refeeding patients who are choosing not to eat, were core features of all 3 presentations, underscoring the highly charged nature of this fundamental task. Likewise, the principles of personal autonomy and professional beneficence are not always aligned. Autonomy is the ethical principle typically invoked by adult patients to decline intervention when they are hospitalized for malnutrition in the setting of their anorexia nervosa. Distress, including moral distress, can arise when the motivating factor for motivating factors for treatment teams, such as doing good or the loftier goal of making a difference in a person's life, clash with the patient's expression of autonomy and self-determination. Capacity assessments are often expected and attempted by treatment teams when complex medical decisions need to be made, but can lead to distress and confusion because they must be nuanced, taking into account factors such as developmental age and cognitive changes brought about by illness. They are, therefore, challenging. The consultants, such as ourselves, that they bring onto the team are then often tasked with determining and reevaluating decision-making capacity. Continuing with a case-specific review, Dr. Jacobson described the challenges of youth in congregate care and offered strategies for championing emerging autonomy that are ethically grounded. Dr. Ortiz-Aguayo offered a formulation of the challenges related to ethical tensions in the treatment of transitional age youth with developmental disabilities that was rather Ericksonian in its structure of the resolution of these conflicts. His presentation also highlighted the importance of transition planning from pediatric care to adult medicine and offered guidance for this process. Dr. Rajagopalan considered the tension between the two values of autonomy and beneficence with transitional age youth who may present developmentally younger, as is the case with many patients with eating disorders, and addressed some of the challenges with surrogate decision-making in this population. As noted by our three presenters, the pitfalls encountered by treatment teams managing eating and feeding disorders in medically complex youth often arise when treatment threatens the patient's sense of control and self-determination. So not surprisingly, they resist. Resistance to treatment is already unusual. Most patients in the hospital want treatment, agree with treatment, and cooperate with treatment. The fact that patients are often receiving treatment against their wishes leads to distress, their own and their care teams. The care team may be distressed that their efforts to help seem to be doing harm, or that care delivery may be systemically inequitable. This distress is designated moral distress. Other reactions, which we recognize as countertransference reactions, can be disconcerting and disturbing, leading to negative emotions and behaviors toward or against the patient. Such reactions can range from confusion about the caregiving role, such as, am I really here to just feed the patient? To hostility, which is often associated with resentment. Ethical complexities can undermine the care team's sense of competency and self-efficacy. A limited sense of self-efficacy can contribute to caregiver burnout. In addition to the practical care strategies discussed by our presenters, including multidisciplinary team alignment and complex shared decision-making, it is important to address team self-efficacy. Doing so promises to support creative problem-solving and collaborative management of transitional age youth with medical complexities. Among such approaches are bringing together multidisciplinary teams, especially when members can remain consistent, requesting ethics consultations, especially around decisions about coercive interventions, supporting peer or collegial supervision, especially for maintaining dispassionate interaction rather than accommodation of difficult patient behaviors. Other practical supports address efforts to promote resilience and a sense of competency, which is a component of self-efficacy. To manage moral distress and countertransference, team members can learn to recognize their triggers and to master stress reduction techniques. To counteract burnout, it can be helpful to limit caseloads and ensure time for leisure or hobby or family activities, and also to balance empathy with distance. Fundamentally, this session focused on strategies that have the potential to improve outcomes in a population of patients who present challenges for their treatment teams. Understanding the ethical and developmental challenges complicating already complex patient presentations can provide patient-centered approaches to treatment. Likewise, recognizing and ameliorating clinician reaction to patient symptoms can help to mitigate moral distress and caregiver burnout. This is the source material for my presentation. And with that, I'll thank you on behalf of our presenters. We hope that you found this session informative and valuable.